Doc Talk with Dr. Paul Conley is copyright 2021, Signer Foundation, and is solely responsible for the content.
Hello, I'm Dr. Paul Conley, and thank you for tuning in to another episode of Doc Talk. This evening we are back at Dr. Andrew Petersen's Ear, Nose, and Throat Clinic. Tonight we're going to be talking about reflux. Reflux, or GERD, gastroesophageal reflux disorder, is something that's very, very common in the United States. Upwards of 20% of Americans have gastroesophageal reflux disease. This is a disorder where stomach acid gets up into the esophagus, but also from an ENT perspective can get up into the throat and into the larynx, affecting someone's voice, affecting even things as far as coughing and wheezing. There's so many different side effects from GERD. Dr. Petersen is going to kind of walk us through from an ENT perspective of gastroesophageal reflux disorder, and actually during the broadcast he's actually going to perform a fiber optic exam on myself. So again, Dr. Petersen, is so good to be back inside your clinic again. You know, we've done some prior episodes here before, but this is something that, you know, I think is going to interest a lot of people, because we did do a Doc Talk procedure on Dr. Scott Kilmer, one of our local general surgeons, and on that episode we talked about how important it is to diagnose gastroesophageal reflux disease. From your standpoint, we're talking about something called LPR, which is kind of a term that's used in the ENT world. So maybe you can talk to us a little bit about how it's all encompassing LPR, GERD, and how, as an ear, nose, and throat, how you would approach that. So maybe let's just start off, you know, what exactly is LPR and what's actually happening that causes that?
Yeah, absolutely. Thanks for having me on the show again. This is a great topic, one, because it builds on previous episodes, but two, because this is one of the most common things that I see in my clinic, and it's often one of those kind of unknown entities or unknown pathologies that patients don't necessarily realize that they have. So let's break down the terms. LPR, that's the term we use in the ENT world, laryngopharyngeal reflux, compared to the term GERD, GERD, gastroesophageal reflux disease. The anatomy there: GERD, gastro, stomach, esophageal. That's your world, that's your clinic. Laryngopharyngeal, that's the voice box in the throat, and that's why patients come and see me. So these are different manifestations of the same disease process, where you're getting not just stomach acid, but stomach contents, including pepsid, gastrin, other compounds that make their way not just into the esophagus, but as high as the throat, and cause different symptoms there. It has lots of different manifestations in the ENT world, not just in the throat, but even as high as the mouth, the nose, and the ear. And we'll talk about that a little bit later.
So, you know, one thing too that I want to make sure people are aware of is that you now in your clinic, you have Jamie Settle. Jamie is a physician assistant who has actually been, you know, with Plateau Health in the past, and so she's no stranger to the operating room. I know she helps assist you there. But also, Jamie, you know, you started here and now you're with the ENT clinic with Dr. Petersen. So, again, it's a pleasure to see you back, you know, Plateau Health. So, you know, we were talking about, you know, before even the show about maybe you can describe, you know, what exactly is happening when we talk about GERD, LPR. So just tell me, like, what's going on? You know, what's causing this?
So typically we're getting some acid secretions that's coming up from the stomach, up through the esophagus, and hitting in the back of the throat and in the larynx, and can even affect the voice box, and as Dr. Petersen said, can affect the nose and the mouth and the throat. We get a condition, what's called silent reflux, and a lot of our patients will come in and they're like, well, I don't have heartburn and indigestion, therefore what I have can't be from reflux. Well, that's why we call it silent reflux. So the lining of the esophagus is actually a thicker lining and more similar to the stomach, whereas the lining of the throat and the larynx is a respiratory mucosa, more similar to the lining of the nose and the mouth. So the lining of the throat and the larynx is a lot more sensitive to gastric contents, reflux, and acid than what the lining of the esophagus would be. So you could have a small amount of reflux coming up, not enough to irritate the esophagus and cause actual true heartburn and indigestion or discomfort in the chest and stomach, but enough to cause other symptoms in the back of the throat, like laryngitis, a chronic cough, a tickle in the back of the throat, feel like something's in the back of the throat, a little burning sensation back there.
So I guess, Dr. Petersen, back to you, this question would be, is this something that you see fairly often? Is this something that, presents, rarely? Is it something you see quite often in the clinic? And again, to Jamie's point, what are some of the symptoms that would, because I think a lot of people don't really think about these symptoms as being LPR.
Sure. I see it every day, multiple times every day, and your description was spot on. I mean, that is what's happening, and this concept of silent reflux or upper airway symptoms in the absence of heartburn is something that we see every day. So you talked previously of the classic GERD symptoms, dyspepsia, belching, indigestion, heartburn. With LPR, think higher, so think the throat. So irritations of the voice box, hoarseness, maybe some trouble swallowing, or it just feels clunky and forceful when you swallow. There's a term that we use called globus sensation, and that's the feeling of something stuck in the throat. Kind of low-grade chronic cough or throat clearing. Patients will often do this, and I demonstrate that, and they are immediately like, oh yes, that's it. I do that all day. I think one of the biggest overlappers, or potentially, the hardest for me to tell the difference is postnasal drip. People come in and they're certain that their symptoms are due to nasal drip allergies from their nose, and their symptom is truly, I feel it in my throat. I feel it running down my throat, and it burns and it irritates. So I've been taking maximal allergy medications for the last 5 years, and they haven't helped. And the reality is, because it might not be allergies, it might be a reflux-caused event where you're getting reflux irritation of the throat itself.
In the GI clinic, one of the things we think about too is some of these, like you're talking about, nocturnal symptoms, where someone, when they no longer have gravity, basically on their side. So when you lay down at night, now you're laying flat. Acid stomach, especially, at the lower esophageal sphincter, is allowing acid to roll up. And people a lot of times will say they wake up wheezing or gasping, or sometimes just cough. They don't cough when they're upright, but when they lay down. Mm-hmm. But I think too, especially, in areas like here we have a lot of allergies. I'm sure there is some overlap, and I think as an ear, nose, and throat specialist, sometimes they're not mutually exclusive. You could actually have LPR and seasonal allergies, and so you're actually having to piecemeal these things out. So I guess this question, is for both of you actually. So, when we talk about GERD, in the episode we did with Dr. Kilmer, we talked about some of the risk factors, and so I want to ask you, are some of the same risk factors the same for LPR? We talk about risk factors, we talk about, male sex, we talk about smoking, obesity. So tell me, are these the same risk factors one would see with LPR, and if so, what are some of the risks that people, can maybe even try to mitigate so they don't have LPR?
I'll take it, because I like the concept and the conversation of lifestyle medicine, and it's the answer to that question. Yes, there are a lot of the same risk factors, which includes obesity, poor lifestyle habits, which revolve around poor diet, and which does include what you're drinking throughout the day. Smoking is certainly a large contributor to this. Yes, it is commonly seen in males, and I think some of that reason is that males practice some of those bad lifestyle habits.
We're bad at that.
Yeah, we are. This is largely a lifestyle and behavior caused condition, and so that's an unfortunate bit of news. The good news is the mainstay for treatment is around lifestyle modification.
Yeah, one of the things is, like you said, I think we males tend to do things that are, detrimental to our bodies. Eating late at night, okay, so when you're going to bed, you have a lot of food in your stomach, refluxing up, smoking, or smokeless tobacco, just nicotine use in general, carbonated beverages, I think people don't, we're in an area where we drink a lot of soda pop. And carbonated beverages, when you, like you said, when you burp and belch, as you said earlier, when you riff, well, when you burp and belch, acid's coming up with that. And that's all coming up the lower esophageal sphincter, up into the esophagus, and in your situation, it's coming up into the throat. So I think, people that have some of these symptoms that, if you're, using nicotine products, if you're drinking caffeinated beverages, if you're eating large meals, especially before you go to bed, by adjusting these type of things, many times you could, like you said, you could mitigate some of these symptoms.
I think that eating right before bed, if there's one habit that is the most bang for your buck, it's the elimination of the midnight snack, the eating right before bedtime.
And alcohol too. A lot of people like a glass of wine right before you go to bed. Well, a glass of wine right before you go to bed is usually coupled with some type of a snack, and then you get more reflux in the middle of the night.
2 hours before bed. That's how you do it.
Yeah, and the reality is that I'll even go 3 hours because some of the things in the GI world, some of these folks especially will see gastroparesis, and sometimes these folks it takes a little longer to clear the stomach, and so especially with diabetes and it can be idiopathic, but gastroparesis, which is a condition when the stomach doesn't empty as well as it should. So to give us a little bit of cushion, I always tell people like 3 hours. So if you go to bed at 10 o'clock at night, cut it off at 7. Just kind of make it simple. So I guess we did an episode actually with Dr. Heather Claudius, our sleep specialist, and again, this goes with obesity, but it turns out that people that have obstructive sleep apneas or gasping and stuff at night, that also seems like they can pull acid contents and stuff over their esophagus and also their throat as well. So someone comes to your clinic, guys, and they have these symptoms, okay? So they say, hey, listen, you know what? I have a lot of these symptoms I'm seeing on the show, and they come in to see you folks. How do you diagnose that? What do you guys do next to diagnose it? Yes, this is what you got going on.
Well, the first thing, of course, is just a good history, trying to find out what exacerbates it. And a lot of times they will tell you, well, I realized I ate right before bed, and I woke up and I was clearing my throat. I was hoarse the next day. And then, you of course, ask how much caffeine they have, how much nicotine they have, what they typically drink throughout the day. Once the history kind of clues us in that we think it could be LPR, we've got a flexible laryngoscope that we will take to look in either through the nose or the mouth, and it's very small, and we end up going into the back of the throat, into the larynx, and there's classic characteristics that you can see: irritation of the back of the throat and the larynx from that acid coming up. And that's one of the biggest suspicions or the biggest diagnosis is doing that. And then talking to them about what they've tried in the past. A lot of times they will have the intermittent heartburn. We all get it. We ate something that we shouldn't have and we have heartburn, so they'll try someone's Nexium or an over-the-counter Nexium or Pepcid. And a lot of times if you start asking them, they'll see some relief of their laryngitis or their clearing of the throat. So that's another key to diagnosis.
So is that something you guys do here in the clinic?
We do it every day, flexible laryngoscopy for multiple of these symptoms. Like she said, it's a small scope, it's easy, it's high def. We have wonderful equipment here in our office. Family members get to see the exam, which they often love. And it's relatively painless. I mean, there might be some uncomfortable nature to it occasionally, but it is a very well tolerated procedure done awake here in the office, as opposed to a camera down into the stomach, an EGD, which might be done in the hospital with you.
So sounds like, can we do that here? Can we do that on me?
We absolutely can.
So I tell you what, we're coming up on a commercial break, and I have just asked Dr. Petersen if he would be willing to do a laryngoscopy on me. So we're going to take a commercial break, and when you guys come back, Dr. Petersen is going to get me prepped here, and we're going to actually do a laryngoscopy on me. So stay tuned, and we'll be right back.
Doc Talk with Dr. Paul Conley is copyright 2021, Signer Foundation, and is solely responsible for the content.
Welcome back to Doc Talk. I'm Dr. Paul Conley. We are here with Dr. Andrew Petersen and Jamie Settle, physician assistant. So we've been talking about LPR, we've been talking about gastroesophageal reflux disease, and now Dr. Petersen is going to actually demonstrate how he can identify this with a laryngoscopy. So Dr. Petersen, what actually is a laryngoscopy?
Sure. So this is a laryngoscope, a flexible laryngoscope. It's a small 4 millimeter diameter flexible camera that has fiber optics in it, and it's very high definition, and we can display it on a monitor that we have here in the room, and it's used to look into the nooks and crannies and hard to see places of ear, nose, and throat anatomy. Usually that does include the larynx and the voice box, which is what we're here talking about today. And
this is something you do every day, like right here in the office. I know we talked about, myself doing EGDs. That's something we do in the hospital for the most part. You can do it as an outpatient setting, but this is something that you do like right here in your clinic.
Correct, yep, and I would say this is a similar procedure in that it can be done in both settings, but it's something that is frequently done just on the fly with a normal patient visit here with the patient awake during a normal outpatient visit.
So not only can you look and see, like say if I have LPR, but you can also look for like polyps in the vocal cords and things like that. Because I know sometimes I'll do an upper endoscopy and I'll see a little something in the vocal cord, but really my procedure is not really designed to do that. I will send these people many times to you, and then is this the tool you would use to look at those suspicious lesions or things I may see on an EGD?
It is, and one of the benefits here is patient is awake and they're sitting in an upright position, which gives me the luxury of having their airway much more open so that I can see those structures with maybe a little more clarity and better visualization, whereas if a patient has had a little bit of sedation and their airway is collapsed, it's harder to really focus on the nuance of some of this anatomy. So that's really one of the main values of doing it here in the office.
All right, I'm ready.
All right, let's walk through the process. So step one, this is a relatively pain-free procedure, but we like to use some local topical anesthetic to numb the nose a little bit, just to make it more comfortable for the patient. That's usually done with a little lidocaine spray that we then also have mixed with Afrin, which is a nasal decongestant most people are familiar with, that helps to vasoconstrict and decongest and open up the nasal passage just so there's more room to pass. So as I would with any patient, we'll go ahead and spray you for that. I'm going to give you a tissue.
Although in general, Afrin and ENT doesn't get along too well. You don't really recommend using that like chronically.
It should not be a daily use nasal spray.
Avoid using Afrin.
You can't say that without that caveat.
Under the personal and professional skills of yourself today, we're using Afrin.
It is a medication I use very frequently for different purposes. So let's do a spray. So here we can kind of demonstrate that. It's just an atomized spray. Does not hurt to come out. We're going to go ahead and spray on both sides of the nose. Good. Now that I've sprayed, just go ahead and sniff in a little bit. Try not to blow your nose for a few moments. Okay. You can breathe easily.
It's easy for you to say.
Yeah.
So it takes a few seconds for this to work, but it works as a decongestant, so it does help with the swelling of the nasal turbinates, making it easier to pass the scope through the nose into the back of the throat. And then lidocaine is a mild numbing agent, just to make it a little more comfortable.
If a patient has an allergy to local anesthetics, which does occur occasionally, we skip the lidocaine and we just use Afrin, and that works just fine.
And people do really good without needing the lidocaine too.
That is correct. So I'm just getting the camera set up and we'll get it nice and focused.
It amazes me, with the technology that you have, like right here in your clinic. We've done some other episodes that people can see where we've done, sinus eval and ultrasound you guys do here, and I just think this is something that's great that you're actually able to do like right here, in the office, like on any day you're doing this. So
it's true, and it's one of the things where we need to give kudos to our parent company, Plateau Medical Center. They have outfitted this office extremely well. I would argue that this is one of the better equipped ENT offices in the state as far as the technology that we have here. So now that we have our camera set up, I've got it hooked to a camera here that's then displayed on a screen up above. And so you're in great position like you are, just
Okay.
kind of looking straight at me. I might even turn you towards me just a tad. I'm going to go ahead and start to look inside your nose and see which side looks easier to pass. There's your mildly deviated septum that we saw on a previous episode.
Still there.
Still there. We'll go back to this side though. That looks nice. So here we are. We're going to traverse the nose and wiggle into the back of the nose. This is, I always tell people, this is kind of the worst part of the exam. Great. I'm already in the very back of the nose. Jamie, if you'd like to narrate a little bit, I'm looking at the adenoid there.
Yep, so in the back of the nose you'll have adenoids. Adenoids will typically decrease and shrink over time. Whenever we do tonsillectomies, a lot of times in younger kids, we will actually take care of the adenoids as well. But on the top of the screen is the adenoids. The eustachian tube is that tube-like hump that you're seeing kind of coming out from.
There it is on the other side.
Yep.
Good. We're going to drop
Now,
down.
Coming back into the back of the throat. The little lip that you're seeing in the very bottom of the screen is actually the epiglottis. And now that he's coming up a little bit, you saw him move.
Yeah,
What movement
I
is?
swallowed and I felt the fiber optic scope.
And the talking that you're seeing in that very bottom part of the screen is actually the back aspect of his tongue. And now the little lip is the epiglottis, which is what covers the trachea whenever you swallow. Starting to come into the first part of the vocal cords. So you can see the actual tissue around the vocal cords, that little triangle shape. There's a very pale, lightish white color that's in the very center, a little deeper. That is your true vocal cords. All of the pink around it is just the laryngeal structure of the supporting structures.
Yeah, so you can see the vocal cords, the V-shaped structures coming together. 6 o'clock on the screen. That's to the front of the body. So let's have Dr. Conley talk and tell us. Can you feel any pain right now?
I feel no pain whatsoever. Are my vocal cords moving?
Wonderful. They're moving great.
Good.
As you can see, vocal cords come together when you speak, and they open up when you breathe in. So take a big sniff in. Wonderful. Good.
So those vocal cords got bigger whenever he sniffed and then come together to vibrate whenever he talked.
And then as we're looking here kind of at the 12 o'clock area on the screen, that's where the larynx turns into the esophagus. So that's the upper esophageal inlet. That is one of the areas we see the classic findings of reflux when we're doing these scopes. I'll say you have a mild amount of swelling of what we call post-cricoid swelling associated with reflux.
Oh, good.
There at the hypopharyngeal portion of the exam. I would rate it as mild, but perhaps you do need to be on a little Pepsid or something, Dr. Conley. Let's have you stick your tongue out for a
Or
moment.
maybe I just need to stop caffeinated beverages.
A little less coffee, yeah. Have you stick your tongue out for just a moment. Let's see, there we go. That's kind of the vallecula. That's kind of this little space there. That looks great. Little cancers and tumors of even, the benign variety also hide there occasionally.
So the vallecula is just that empty space that you're seeing behind that lip-like structure, which is your epiglottis. It's what the actual indentation that the epiglottis makes.
And that's it. We just slid back out. That's a flexible laryngoscopy exam. I'll say, so that is one of our better cameras that we have, but we also have different flexible scopes that do different purposes. We have one that we set up to a special monitor, and it displays a strobe light effect. And so if you think of the strobe light when you're in the haunted house and everything looks slow motion, that's what it's doing. It's called a video stroboscope, and it's turning that we just saw into a slow motion version, so you can really pick up nuances of the vocal cords themselves, like little nodules, singer's nodules, cysts, stuff like that you might miss on an exam like the one we just did.
So we're talking about some other more words. I heard you talking. I heard you say the word cancer. Oh, I hope you're not seeing that in me. But this is something that if you had a patient who was having some, throat pain, a smoker. These are the type of individuals that you would perform something like this and could make a diagnosis of something like that, right?
Absolutely true. It is a common visit that patients come in with the symptoms of LPR that we've discussed, but in the back of their mind, they're worried that they might have a growth, a tumor, a cancer in their throat. Maybe they have family history of it. This easy, quick procedure allows me to look in, and I can confidently look at a patient and say, you have no lumps, bumps, growths, tumors, cancers, bad infections hiding in your throat, and things look good. Or on the flip, sometimes we do find things, and the goal is that we find these things early. And that's why it's important that you present early with symptoms so that we can find things early in the process to improve outcomes.
So, real quick, as we're getting ready to come to the completion of the show, you had just mentioned to me, you said, hey, maybe you might want to be on some Pepcid. Okay, so we talked about, Jamie, you mentioned about, diet modification, weight loss, avoidance of caffeinated beverages, carbonated beverages, but medical treatments. Okay, so you'd mentioned Pepcid, famotidine is a generic. When do you prescribe that, and maybe how does that help with LPR?
Well, whenever we're seeing signs and symptoms of the irritation and the history is consistent with LPR, if they're not already on a PPI, so a proton pump inhibitor, so something like Nexium or omeprazole or Protonix, we like to go ahead and start that. Then, if they do get intermittent heartburn, then add the Pepcid on top of it if it needs to. We like to try that for a good 2 months to see if they have relief of symptoms after starting a PPI.
So, folks, I appreciate you coming on the show. We're out of time. I'm Dr. Paul Conley. You've been watching Doc Talk, and until next time, have a good night.
Doc Talk with Dr. Paul Conley is copyright 2021, Signer Foundation, and is solely responsible for the content.